Oh, hi, Kevin. Fantastic. Great. He is currently Regional Director of Public Health at London, but he has held senior level posts at the US CDC, and then coming back to the UK for a senior leadership role in Public Health England in the field of infectious disease, and then actually rolling up his sleeves also and doing work in a Southwark council. So, basically very familiar with public health on the ground and at the in the governmental policy making levels. So Kevin was awarded a CBE for his services fairly during COVID, and has played a leading role in COVID during the last couple of years. And he's also, delighted to say, incoming president of the Faculty of Public Health later in this year. So Kevin, thank you so much for joining us online. And I'm so sorry that you can't be here in person because of the rail strikes, but we are becoming completely adaptable. Now, can we hear you? That's the key thing.
I hope you can. Can you hear me?
We can hear you, yes.
And I'm going to project my slides. Can you see them?
We can. We're in a 19th century room, and they're rather small, but I think we've got 4 projected around the room, and most people can see something reasonably close to them, I hope, without craning their necks too much.
Okay.
So, over to you.
Great. Well, Carol, thank you so much, and good morning, everyone. It's really a pleasure to be here with you this morning, and also a pleasure to follow such an exciting first speaker for the session today, because I think that panoramic view of our experience through COVID and seeing that experience through different lenses is going to be a key part of both the lessons from the pandemic as well as the legacies of the pandemic, and understanding where we did things well and where we could have improved, or where we did things really badly. I think that level of honesty is certainly going to be key in ensuring that as we recover and as we think through ways in which we improve health and tackle inequalities, we build in those lessons from the pandemic. So colleagues, in the time that I have available today, I really wanted to do 3 things. First was to step back. We've had 2.5 years of the COVID-19 pandemic. As we are in the midst now of recovering not only elective services and emergency services in the NHS, we're recovering preventive services as well. And I wanted to take a look at where we are in terms of non-communicable diseases, health inequalities more generally. Second, I wanted to do a little bit of reflection on the health and system transformation that we're going through at the moment. And as many of you are aware, in the middle of the pandemic, we disbanded Public Health England and created new public health agencies, but we're now in the process of transformation in the NHS as well. Now, these transformations bring their own challenges, but I would argue that given our experience in the pandemic and the transformations, we have some new opportunities for tackling inequalities. And then I'll end by making it real. I'll share with you some of the ways in which we are truly building on the lessons from the pandemic in London, the new governance, the new ways of working, and innovative programs that we're launching that really shows that emerging from the pandemic, the legacies in tackling inequalities will shape what we do in public health in the city. So just to get started then, I think the first, looking at the first slide to move, one of the things we are all in the business of in public health is ensuring that we're helping everybody to live longer and healthier lives and to reduce disparities. And in fact, the new Office of Health Improvement and Disparities has this as the key mission statement in terms of what we're trying to do in public health in the United Kingdom. And certainly over the past 200 years, we have seen significant improvements in health and length of life. We've seen life expectancy more than double from around 40 in the 1850s to around 80 now. So certainly we've been seeing increases in life expectancy, and we've been seeing improvements in healthy life expectancy as well. Although for both of those measures, as you will see shortly, we're beginning to see stabilization in the rates of increase in those measures. Now, much of the successes that we've had are attributable to not just improvements in medicine, but improvements in the social and economic lives of Britons. And this includes the availability of better sanitation, clean water, education, improvement in healthcare services, better working conditions, and a focus on improving health across the life course. Yet despite this, and despite the improvements that we've made over the past many decades, we're now beginning to see things slowing down in England and in the United Kingdom. And as you've heard from the previous speaker, the pandemic itself will have both direct and indirect impacts on these trajectories, which will be a key feature of how we recover and how fast we recover from the pandemic. Now, not only are we seeing these big changes in life expectancy and healthy life expectancy, there are areas of concern, and these predated the COVID pandemic and have been worsened as we've gone through the pandemic to where we are today. So as I said, we have been seeing improvements in life expectancy, but you all know that we have significant heterogeneity across the country, both in terms of across different communities, different areas of residence, and even within regions, you see significant intra-regional variations, as well as variations across the country. We see the concentration of both infectious disease and chronic diseases in areas of deprivation, and these concentration of infectious diseases and chronic diseases have in fact worsened as we've gone through the pandemic. We'll look at some of those data as well. And as we're experiencing demographic change within the United Kingdom, we're also seeing diseases of elderly individuals becoming more of a feature of the patterns and distribution of diseases which we see, and that must require us to rethink how we shape and deliver health and care services to meet the changes of our demographic profile and populations. And a key part of that is the multicultural, much more diverse communities that we have in Britain today that also requires us to think differently about our health and care services. And a fourth key feature that I'm particularly concerned about is the concept of multimorbidity, that more and more people are living not just with one or two chronic diseases, but they're grappling at any given stage with multiple chronic conditions, which means that not only do they need holistic and integrated care, but we also need to be thinking about how we reconnect the mind and the body and the social when it comes to improving health and well-being across the population. And that integrative process of whole health must be a part of our narrative of recovery in the country as we come out of the pandemic. So let's look at a few data points just to show some of the changes that we're seeing and the magnitude of those changes. This first chart just shows changes in life expectancy over the past 2 decades, comparing the United Kingdom in turquoise against other Western industrialized countries. You can see in this slide, we're about in the middle of the pack, you see the increases which have occurred over the past 2 decades, but you also see this relative slowing down more recently. When you look at some of the variations that we're seeing within country, although we're seeing improvements overall in life expectancy with the more recent slowing down, that experience of improved life expectancy varies tremendously depending on whether you live in least deprived areas, where we've seen improvements in life expectancy in all of the regions where in least deprived parts of the country, we've seen consistently improvements in life expectancy. But in the most deprived parts of the country, life expectancy has been falling. And the only exception there regionally is in London, where we continue to see increases, although at a slower rate in life expectancy. So again, this is about the heterogeneity that we're seeing and the importance of understanding the significant impact of economic deprivation. Again, focusing on life expectancy, as you would imagine, we see significant geographic heterogeneity. The orange and brown shading on this slide shows areas with lower life expectancy and are generally seen and clustered in the north and the Midlands in the country compared to the south and southeastern parts of the country as well. Now, a key part of what we've seen over the past 100 years, and certainly more recently, is the reasons why people are dying continues to evolve. And these plots show, both for females on the left and males on the right, the leading causes of death over the past 100 years. And you can see clearly, as you move from left to right in each of the bar charts, you can see the increasing contribution of chronic conditions such as cancer, as well as neurodegenerative conditions. And you have the declining influence of infections in turquoise as a leading cause of death, both for women and for men over the past 100 years. Again, this change, this dynamic picture that we're seeing, the differences by gender, the differences by area of residence and deprivation are key. I previously mentioned the importance of multimorbidity, the presence of multiple long-term conditions. And here we're looking at the ways in which we're beginning to see multiple long-term conditions accumulate across the life course and across age cohorts. So with increasing age, people begin to develop their first, second, and third multiple long-term conditions, placing increasing economic burden on health and care systems, but also creating complexities for the real lives of people as they're grappling with the health service and managing their care. And you can imagine that in an environment where patients may need to go to 2 or 3 different specialists to get their diabetes, their heart disease, or their cancers managed, then as we move into more super specialization within the NHS, that places increasing burden on individuals to navigate the healthcare system. And that's even more marked when it comes to people who may have low trust or low self-efficacy when it comes to engaging with the healthcare system around their health. Now, the reasons for the changes that we're seeing, both positive and negative, are rooted in a number of the individual, behavioral, healthcare access, as well as economic determinants of health. These wider determinants of health, as well as the individual and structural determinants, are key. Here I'm going to show just a few trends that we're seeing in some of the risk behaviors for non-communicable diseases, and therefore drivers of inequalities, as well as premature morbidity. One of the success stories for public health in the United Kingdom is we've had the declines that we've been seeing in the reductions in smoking rates. And this has been consistent over the past 2 to 3 decades, and is the culmination of the impacts of the number of multi-level interventions which have taken place, including policy interventions, multiple campaigns on stopping smoking, better clinical services to help people to quit, as well as engagement and targeting of anti-smoking interventions in the most deprived parts of the country. And that combination prevention approach that we've used for smoking has also been the principle that we've used to reduce rates of HIV incidence in the country, even though we do see significant variations, again, associated with economic deprivation, with more deprived parts of the country having higher rates of smoking. But again, the trajectory for smoking has been downwards, even though we're beginning to see some slowing in that decline, again, as a result of going through the pandemic. We can look at other conditions which are also drivers for the changes that we're seeing in life expectancy and healthy life expectancy. As you know, obesity, childhood and adult obesity are major public health challenges and priorities for us nationally. We are seeing increases in the proportion of the population who are either obese or are overweight, and that we're seeing that occurring earlier as we're seeing increases in child obesity. And this increase in childhood obesity follows through individuals as they age and across the life course, with attendant complications, with increasing the risk of non-communicable diseases, multiple long-term conditions, and premature mortality. Another key factor, and perhaps in an inverse relationship that we see, is changes in patterns of alcohol use over time within the United Kingdom, and we're seeing increase, and especially in England, increases in harmful alcohol use as increasing proportions of the population are now consuming alcohol above the recommended levels. Again, some of these patterns have accelerated as we've gone through the pandemic. And in this slide, we look at the variation or the heterogeneity, both by age group on the left, where you see peaks in increasing alcohol risk occurring in middle adulthood for both males as well as females. But when you look at the risk by deprivation, converse to what we've seen with cigarette smoking, we see high levels of alcohol risk, especially in least deprived communities compared with the most deprived communities. And that has issues to do with patterns of drinking, access to and the ability to afford alcohol, and of course, changing cultural norms around alcohol use. The final sort of issue that I wanted to focus on very briefly was physical activity. And as many of you have heard me say, that if I had to say that there was one thing that we could do as a nation to really help to improve our health well-being, both physical and mental well-being, would be to increase levels of physical activity. And here we see significant heterogeneity across age groups. As you would imagine, the younger you are, the more physically active you are. And as you age, that level of physical activity decreases, as shown on the left. And on the right, we also see a significant economic patterning of levels of activity, with people living in less deprived parts of the country being far more likely to be physically active than those in more deprived parts of the country. Now, I really wanted to pull out this intersection between risk and the economy and deprivation, because as we emerge from the pandemic and we're now moving into a cost of living crisis, greater food insecurity, greater job insecurity, and housing insecurity, these are all likely to accelerate and make our efforts to tackle ill health, non-communicable diseases, and health inequalities more challenging. As you know, we're seeing significant increases in the rate of inflation, and currently it's at a 40-year high. These data show both the patterns across the United Kingdom as well as in London. And this increase in inflation is going to have a material impact on pushing more people into poverty, as evidenced by data on food bank use, but also changing how people are able to purchase health, engage in health, and to ensure that they're taking care of reducing risk. Now, the cost of living crisis is not being experienced uniformly across the country, and data that we've looked at in London certainly shows that across different sectors, depending on what you're doing, the level of resilience you have economically is going to be very different, and therefore your ability to navigate the cost of living crisis is going to be difficult. And here we can see that although the median employee pay in London was about 5.9% below 2019 levels, in 2019, the gap we're seeing that much wider in the United Kingdom. And here we can see employment such as finance, information and comms, professional services, faring a lot better than occupations such as construction, hospitality, entertainment, and other services. So where you are and where you're starting in the cost of living crisis, depending on sectors, which also have an impact and are demographically patterned, will certainly determine the impacts that people are seeing when it comes to their health. In London, this is having a material impact. We're now seeing significantly more people claiming universal credit, although we saw that peak during the pandemic. As we're leveling out and coming out of the latest phase of the COVID-19 pandemic, we're seeing that the projected universal credit claimants have continued to increase over time. And in fact, they're at a higher level than the trajectory pre-pandemic would have suggested. So the cost of living crisis is manifesting itself itself in many ways. And one of the ways in which it's doing so is what and how Londoners are struggling to contend with financial crisis, how Londoners are managing their living costs, illustrated in the bar chart on the left, where people are spending less on non-essentials. They're buying cheaper products. They're using less water, energy, and fuel. They're stopping or delaying non-essential spend, and they're saving a lot less. Again, from our polling data and research in London, we're seeing these material impacts. And then when we think about how financially struggling Londoners are managing costs, again, people who are coming into the financial crisis who were either working poor or at or below the poverty line, we can see that the major effects there are buying less food and essentials, spending less on non-essentials, and of course using less water, energy, and fuel. So we're coming out of the pandemic. We've come into the pandemic with real challenges with non-communicable diseases, and now we're beginning to see some of those impacts worsen as we're dealing with the cost of living crisis. I wanted to briefly just mention and reflect on the COVID pandemic, because we do have a moment in time to build upon the lessons of the pandemic and to think of the legacies. And as you heard from our previous speaker, there are many different ways in which COVID is worsening health inequalities. Not only do we have the direct impact of COVID-19 from direct deaths, long-term morbidity from long COVID, but we also have the indirect impacts of mortality due to the impact of COVID on the resilience of health services and the displacement of activity, access, and treatments as a result of navigating the COVID pandemic. And that's why the recovery program in the NHS is so critical. We've seen the indirect morbidity and mortality due to routine and urgent non-COVID related healthcare being postponed, reduced, or cancelled. And the narrative now of reducing the waiting list, the 2-year waiting list, the 1-year waiting list for care is important, but it would be a real shame if the focus is only on recovering clinical services, because preventive services, whether vaccination, screening programs, the NHS health check, all of our activities on physical activity, healthy weight programs have also taken a hit. So I would like us to begin thinking about the indirect impacts, not only on clinical services, but preventive services, and ensuring that those are dealt with as well. And then finally, as you heard before, understanding the direct effects of the NPIs, the non-pharmaceutical interventions which are put in place in the pandemic, both on their short-term impacts as well as their long-term impacts will be key. And among this include mental health effects, the disruption of education, the disruption of employment, and how that will change people's life course and trajectories. Now, going through the pandemic, as you heard before, we really understood ways in which the pandemic has widened our understanding of inequalities and widened those inequalities. And from wave 1 of the pandemic, we began to see disparities in age and sex, geographic heterogeneity in who was infected and who died from the disease. We saw very early in the pandemic the impact of deprivation, as well as the disproportionate impact across racial and ethnic groups. And in the first year of the pandemic, when we looked at the median age standardized mortality rates from all causes from COVID-19 and other causes, we again saw that very strong association with deprivation, with people living in the least deprived parts of the country on the right-hand side of this chart, having much lower mortality from all cause COVID-19 and non-COVID conditions compared to those in the most deprived parts of the country. Now, throughout the pandemic, we've been doing a lot of work to get beneath the data to understand the social, the cultural, the behavioral influences which are driving these differences. And a lot of the work that we've now done has really helped to integrate both the qualitative and the socio-anthropologic work with the epidemiological data. And I'm hoping that this will again be one of the legacies that emerges from the pandemic. But we now understand, as you heard before, the importance of the vulnerabilities that communities face faced prior to the pandemic and how these vulnerabilities accelerated their risk of acquiring infection and dying from the disease. We saw the importance of the kinds of jobs you have, the houses that you're living in, the ways in which you navigate the cities and places, public transportation, for example, as being key risk factors. We use social and anthropologic data and studies to help us to understand poor treatment and management of non-communicable diseases and the reasons why that predated the pandemic and how we need to mitigate those to reduce risk. And then finally, none of us who've been through the last 2.5 years and had to work closely with communities we will always be reflecting on the structural determinants of COVID risk, racism, discrimination, stigma, the mistrust within many of our communities, which again complicated how people navigated the healthcare system, how they used it, how they engaged in services, including the vaccination program. So in the final part of the talk, I wanted to sort of move then from describing the problem into thinking about what are the opportunities for intervention. And as I mentioned, as we've gone through the pandemic, we've also been transforming the health and care system. I think COVID will leave us with a number of key legacies, and those legacies are important for us to build upon. And they include, I think, ensuring that we have well-resourced, multi-level, equity-focused pandemic and public health programs in place to ensure that we learn the lessons from the past, but also build the resilience that we need moving forward. We learned so much and learned so much through working with better partnerships and effective partnerships with our communities. So I would like to see stronger, innovative, more agile partnerships be a key feature of how we begin to design our healthcare systems. And I think the creation of ICSs, ICBs, and integrated care partnerships in the NHS will allow this. Data and the quality of data emerged and evolved as we went through the pandemic, but certainly the quality of the data, the timeliness of the data, the ability to describe inequalities, to target interventions really helped us. And certainly in London, where we invested a lot with our academic partners to ensure that we had a better handle on the epidemic and where to target our interventions. The research agenda and the way we define, deliver research, engage communities, thinking about participatory research methods, I think really evolved through the pandemic. And we're looking at how we use resources with the NIHR and other research funders to truly think about different ways of doing research, which are culturally competent and meet the needs of our communities. And then finally, the investment that we've had in building community infrastructure from community champions, COVID ambassadors, really thinking about engaging in multiple languages, using different channels with our communities must be part of the legacies moving forward. So we can use these legacies in different ways, right? Because we now have the system reform, which is taking place, the public health reforms I've mentioned. We have whole new public health agencies which are now working and thinking about the public health system and the agenda in the future. And when we think of that system, we have the Office of Health Improvement and Disparities in the Department of Health that really is looking at how the Department of Health can influence national government policies, but also integrate much better national, regional to local efforts to improve health and tackle inequalities. Clearly, we've had public health in local government, and directors of public health and their teams have been phenomenal through the pandemic, and they're a key part of the preventive services recovery, which must form part of our actions now. The NHS is changing, the creation of new integrated care systems, partnerships and boards, the looking at ways in which we knit the local government as well as the NHS services in providing more holistic care, and of course the UK HSA focusing on health improvement and protection as well. And when we think of some of these opportunities in place, the job that I'm doing now in London as regional director involves working across system partners, being that connector in place for policies and programs, leading for health and inequalities, working and supporting our local government partners on the delivery of programs. I'm a part of the NHS, so a lot of my work is around helping the NHS to better commission services, focusing on inequalities and prevention. And of course, the role as regional director and OHID in place has a strong public-facing responsibility as well, building upon some of the lessons of the pandemic. Now, while we've been going through a lot of change, the NHS has also been changing as well. And whether it's the direction set in the NHS long-term plan, recommendations throughout the course of the pandemic about a more equity-focused response by the NHS, and more recently, the NHS's Core 20+5 strategy for tackling inequalities, we're seeing the NHS stepping up in calling out, defining, and finding ways in which they should be focused on tackling inequalities. We won't have time to go through this in detail this morning, but essentially the Core 20+5 enables us to focus efforts in the core and the most deprived 20% of the population as deprived by index of multiple deprivation. It talks about the 5 key clinical areas where we need to make progress in tackling health inequalities through secondary prevention, maternity services, mental health, chronic respiratory diseases, cancer diagnosis, and managing hypertension. And it also talks about the plus communities. So apart from looking at economic deprivation, which and who are the other populations and communities which need to be addressed, whether travelers, asylum seekers, migrants, etc. So pulling this together, we now have an NHS that I think is becoming increasingly more confident in tackling inequalities, thinking about their work on Core 20+5 delivery, their work as anchor institutions. So how does the NHS leverage its employment, work practices, purchasing power to improve, especially in place, some of those wider social and structural determinants of health. And of course, the NHS now has a stronger focus on prevention. I'm going to end now by just very quickly just talking about 2 things in London, and in the interest of time, because I'm really keen to hear some of your thoughts. So we've told the story of the journey that we've been pre-pandemic. We've looked at the impact of COVID. We have described the transformation that's happening in the system at the moment. What practically do we now do to lock in these changes so that we tackle inequalities? Well, in London, I think there are 3 things that I'd like to end with today. The first is looking at place as a unit of both innovation, delivery, collaboration, and building upon the lessons of the pandemic. And in the system, we combine looking at multi-level interventions, which begin with our communities, then looks at health and well-being strategies delivered by local authorities, integrates that into the sub-regional planning by integrated care systems, and then brings regional partners together to develop major strategies on health inequalities or vision for health and care or recovery as examples to say, how do we want the system to move together? Now, London is able to do this given our geographic and political sort of coterminosity. Manchester, other urban areas are able to do this as well. And this is exactly the sort of whole system planning which is needed. The second thing which is needed is better governance for equity and inequalities. And again, throughout the course of the pandemic, we have been supported by the Mayor of London to have this resolute focus on tackling inequalities. The London Health Board, which brings statutory partners together, is really driving and overseeing work on equity in the city. We have created health equity delivery groups and governance groups, both for the NHS and wider system partners, and equity is included in our work on London recovery as well. And in all of these, we see a range of new innovations being developed. And here we just highlight a few. Throughout the course of the pandemic, a lot of our work on COVID was not only to manage the subsequent waves, but mitigate the impact on our most vulnerable communities. So that included looking at vaccine equity issues, developing programs on the hyperlocal approach to delivering vaccines, really engaging and working with communities and building that community infrastructure to ensure we have better culturally competent responses. But as we emerge from the pandemic, new equity programs are now becoming key, whether focused on populations such as asylum seekers and migrant health, as we've had to do with the Afghan and more recently the Ukrainian entry into the region, really thinking about and speaking about structural inequalities and organizations being anti-racist, focusing on anchor institutions, not just the NHS, but big universities, businesses, industries in the city, and strengthening and building upon the lessons from our work on homelessness. So colleagues, I'm going to end there now. I really wanted to reflect a little bit on the nature, scale, and pervasiveness of inequalities which we're seeing nationally. I wanted to really reflect on the changes that we're seeing as we emerge through the pandemic. And transformation can be a negative thing because of the disruption, the time it takes for us to resettle, reform, restore, and norm. But I think combined with the lessons of the pandemic, the transformation and that laser-like focus with better governance, better programs, better collaboration, I think we do have a chance to make inroads into these inequalities. So Carol, with that, I'll pause there and thank you so much.
Is for you, but I may be looking at you. But thank you so much for taking us through that sort of journey of the history, almost the recent history of inequalities in the country, but also through the pandemic and also through the reorganization. And I'm glad to hear you framing the reorganization in such a positive way as an opportunity. And I wonder whether, I mean, just to check, have you got time for questions? Because I know we're a little bit later. Yeah, great. I'm sure there will be some questions from the audience, but while you're thinking, I'll come to you, Catherine. I'll just ask mine first, which is how are you getting the integration into the structure that you mentioned in London, basically holding each of those levels to account?
And that's why a focus on leadership and governance is so important, because around the table you have the sector partners with our community partners. And so at the different levels, for example, in the London Health Board, we're able to look at major pan-London initiatives where we're held to account for delivering against those. And then in the health equity governance groups, we're able to think about some of the inclusion health priorities, what we're doing on data, what we're doing in terms of community engagement, much more granular work, so that again, the commitments that we've made to communities as we've gone through the pandemic, a group of partners, including the community, are holding ourselves to account to deliver on those. So, we often don't speak enough, Carol, about leadership and governance as being so essential to delivering on our public health programs. And I'm really trying to, with our London partners, ensure that we commit ourselves verbally and we demonstrate through our governance that we mean things differently, we're acting differently.
Catherine Mead from Anglia Ruskin. Please introduce yourself when you start. And Kevin, I hope you can hear from the mic.
Hello, Kevin. Okay. Can you hear me?
I can, Catherine.
Ah, that's great. Yes, I'm Catherine Mead, Professor of Health at Anglia Ruskin. I'd like you to describe, if you could, why it is that the ONS or any other public bodies made no evidence available around sexual orientation and COVID-19 incidents, hospitalisations, deaths, etc. In spite of the head of the ONS saying, yes, it's important and we should do it, way back in early 2021, no data ever has actually come out. Can you explain why?
No, I can't. And I think this is, and thanks, Catherine, for that question. You and I have spoken about this before, about the limitations of data. And remember, for the first 6 months of the COVID pandemic, we weren't even getting ethnicity data at all. And we had to really push to get the data broken down by gender and then by ethnicity, and then getting the data on residents. I think this is where we need to really pin this down. And Catherine, your leadership on this, I think, has been phenomenal. But we do need to pin down now, our leaders in the health and care system and ONS, about getting the data right, because we've demonstrated through COVID that we can do it. And we should ensure that the lessons of that are taken across to other conditions. There's no justification, I think, today why we're not able to cut our data in much more granular ways to help us to target and to improve health, and to stop making assumptions, as we do with the LGBT community, about their health, physical and mental. And there's too much of that going on at the moment. And I think there needs to be greater accountability in the system when it comes to data quality and availability. So agree with you on that. And I think that's something for us as a system, as system leaders, to really set a much better ambition about.
Great, thank you very much.
Thanks.
Thanks, Kevin. Any other questions? Yeah, John?
Thank you, Kevin. I'm John Ford. I'm a clinical lecturer in public health at the university here. Great talk, and thanks for joining us. So I wondered if you could comment, do you think there's a risk that the NHS or local systems overpromise on what we can deliver in terms of health inequalities? And is there a risk if we overpromise that leads to powerlessness and fatalism within local systems without wider inequalities in income, education, and employment being addressed?
Yeah, so great question. First of all, I'd rather them overpromise than underpromise, because there is something for me about the equity and health equity discussions never having made it above and at the C-suite, in terms of chief execs, chairs, and the board really taking this seriously. So we're now in a place where there's no ICS, there's no part of the NHS that you'll go where equity is not being discussed. Second, I think that part of the overpromising must be breaking this down into bite-sized chunks, so we demonstrate and we ask the NHS to focus on specific interventions that we can hold them to account to. And so that's going to be part of the overpromising. And in London, there are 5 things that I say, listen, if you do nothing, do these 5 things. Number 1, focus on equity, diversity, and inclusion for your staff. Treat your staff well, because the communities see how you treat your staff, and that has an impact on trust and confidence in the system. Number 2, implement the core 20+5 program, because it really defines the sort of where you put your efforts in terms of improving health in tackling inequalities. Number 3, the anchor programs are phenomenal because they allow us to do everything from apprenticeship opportunities, supporting local businesses, having more culturally competent and diverse staff to reflect local communities. Number 4, really focus on how you're engaging with communities. And for goodness sake, if you can't do it as a trust, work with your local government, your local authority, because they have networks into local community. And we must rebuild trust. We have to focus on trust and confidence as a key structural determinant of poor health, and that we need to address, because I tell you, it will have an impact on vaccination programs and screening programs as we come out of the pandemic. And then finally, create environments within the NHS where we come out and are more confident in talking about issues around anti-racism and the structural determinants of health, because these are important. Staff and communities want to understand that institutions understand the importance of structural racism and are looking at ways in which they can do it. And there's a body of evidence now on what organizations can do and should be doing. So great question. I don't mind about the overpromising if there's governance and if we can ensure that we ask the NHS to do a few things at scale for impact. Thanks.
Thanks. Any other questions? Yes, please go ahead.
Hello, my name's Eleanor Turner-Moss. I'm training to be a GP and a public health consultant. I had a question about recovery after COVID and whether enough attention is being paid within the health service and investment to ensure that we don't widen inequalities as we address the backlog. Thank you.
Yeah, that's great. Thank you. As the regional public health director for NHS London, it is part and parcel of our thinking about the NHS recovery, that we think not just about restarting services, but we use the way we recover to identify outreach to the most vulnerable communities, the most economically deprived communities, and to think about how we build our recovery programs, in a sense, not trying to pick off, so to speak, the low-hanging fruit first, so the people who are engaged and are calling the reception 2-3 times a day for their appointments, but to think about looking at the waiting list, understanding the characteristics of the waiting list, and then saying, actually, how do we reduce inequalities in doing so? There are some great projects around the country doing this, and certainly in London, we're applying those. In my presentation, I spoke about the importance not only of the clinical recovery, but you may also want to think about the preventive services recovery program as well, because that is where we're going to have a huge impact on tackling inequalities. Now, pre-pandemic, for cancer screening, bowel, cervical, and breast, we saw significant variations across socioeconomic status and race ethnicity. So in my mind, and for NHS in London, it's not just about getting those services started again, it's about culturally competent engagement and targeting and working with our communities so that we rebuild our screening services in ways that are far more culturally competent than they were before. And those are exactly the conversations that we're having certainly in the NHS in my region. And I suspect in other regions they're doing the same. So great question. And yes, it's at the forefront that we recover and rebuild, but we have equity at the forefront of our efforts.
Thanks, Kevin. I'm aware of one exercise going on in an unnamed region or health system where there isn't any public health involvement in the looking at kind of machine learning prioritization, and it would be really good to be able to integrate knowledge of populations from public health into those exercises. And I think it is a real challenge to. Because the health system has been sort of without public health embedded in it for quite a long time now. So actually penetrating into the right places is quite difficult, isn't it?
It is, I agree. And this is why, with the transform of the public health system, and don't get me wrong, I'm not looking at this through rose-tinted glasses. There are real challenges with transforming in the middle of a pandemic and now going through the NHS transformation. But it does mean that you have regional directors of public health who are on the executive of all regions in the NHS. ICSs, which are being established, have stronger focuses on population health management, and directors of public health being engaged in various levels of the governance. So my hope is that over the next few months, as systems form, we will reconnect the population health and public health back into clinical service delivery with the experience of the pandemic on inequalities. The challenge, Carol, and I think this is at the core of your question, is, and how do we hold systems to account to make sure this really does happen and does work? And that, I think, is where we will need to continue to push and advocate with NHS leaders as well.
Work in progress. Shadrach.
Indeed.
I think we need a mic up here for Shadrach.
Hi, Kevin.
Last
Thanks.
question.
I've seen you spend a lot of time talking about, engagement, equity, and it makes sense, obviously, because I can see you spend a lot of time at the US CDC, and as somebody who spent a lot of time in America, I can see the strong interest. Now, my question, I guess, is, when you talk about engaging communities and all of that, at what level of engagement are we talking about? Is it the NHS, all these public health experts designing the intervention and then involving them, or starting from the bottom up? I mean, grassroots, and co-designing with communities and building up from there. And if you're able to do that, by that I mean the co-designing, given how scattered the UK is, right? Especially in a setting like London. How does that happen, and how do you make it happen? Thanks.
Yeah, great question. What's your first name, please?
Shadrach.
Shadrach, great. Thank you so much. It's always good to end questions on the community, and I really thank you for doing that, because as a public health doctor, at the end of the day, what gets me excited every morning when I get up out of bed is the ability to make a difference in people's lives. For me, because I started my career as an HIV epidemiologist and infectious disease epidemiologist, and many of you know that I've done work on HIV prevention here in the UK and around the world. We could not have made the advances that we've made in HIV without strong community partnerships. And those partnerships are not tokenistic at the end of the process, but really co-production and co-design with people with lived experiences at every phase of your program development. So whether it is on access to treatment, access to PrEP, all of the major advances in HIV have been achieved through that community health partnership. And I think that has defined who I am as a practitioner. And that is why throughout the COVID pandemic, I think the London response, we were always nagging national and saying, listen, we need monies for community organizations. We want to do more asset-based community development. We want to develop a community champions program. And we were consistently ahead of the nation when it came to, I think, really going deeper with our communities, getting data, briefing communities, town hall events, having community advisory boards, which worked alongside us in many of the COVID response systems. So when I speak about community engagement, it's a deeper and more meaningful one because it builds upon my experience and my knowledge of seeing the power of asset-based community development in helping us to achieve our health goals. And that is the sort of recovery that I would like to see moving forward.
Thanks, Kevin. And we haven't got time, I think, to go into the academic service links, but I think that last point that you've made about having sustainable infrastructures in which we can work together and co-produce the research that it's required. And actually, that's what Shadrach is doing in Ghana. Okay, so I'd like to thank Kevin again for a wonderful talk, and thank you for fielding all the questions. And thank you for joining us despite the challenges.
Great, listen, thanks everybody. Bye.